Scott Nass is a board-certified family physician in Palm Springs, California, and currently serving as Associate Program Director for the Eisenhower Medical Center Family Medicine Residency Program and Director of the Family Medicine Inpatient Service. He holds joint medical degrees from the David Geffen School of Medicine at UCLA and the Charles R. Drew University of Medicine and Science. He is a graduate of the Ventura Family Medicine Residency Program and completed faculty development fellowships at both Ventura and the University of North Carolina, Chapel Hill. He serves as secretary for the board of directors of GLMA, Health Professionals Advancing LGBT Equality. He is past co-convener for the LGBT caucus of the American Academy of Family Physicians, or AAFP, and has served multiple years as GLBT delegate from California to the AAFP National Conference of Constituency Leaders. He was lead reviewer for the current AAFP curriculum guideline in the LGBT Health for Family Medicine residents and was principal investigator for community-based research addressing barriers to care for LGBT persons in Ventura County, California. Scott has a strong interest in healthcare policy and advocacy as well as medical education. So obviously, very experienced person in talking about these issues today. So I'm going to go ahead and unmute you, Scott Nass. Give me just a moment here. All right, Dr. Nass, can you?
Hi, Allison, can you hear me?
Hi, yeah, hi.
Yeah, okay.
So
Great.
Today we're going to be presenting through the screen. Had some technical difficulties, but just tell me whenever to advance the slide and I'll do it for you. And if anyone has any questions, you can put it in the chat box or also in the Q&A icon if you want to send that question directly to Dr. Nass.
Great, thanks, Allison. And my contact information will be at the end, so if anyone has any follow-up questions. But thanks very much to AMSA for having me here. I spent quite a few years involved with the organization, so it's great to be able to participate now as an attending little physician. So on the next slide, you'll see just some quick objectives. We're going to talk about the your ability to rate as valuable the relevance of sexual orientation and gender identity to being able to really provide that whole person health that we do in primary care. Talk about a biopsychosocial approach, considering other factors other than just, what's medically wrong with someone and how other factors in their life can influence their diagnoses. And then talk about specific interventions that you can really do, not just clinically, but in general as well, to improve health outcomes for LGBT patients. On the next slide, my disclosures. I have nothing relevant financially to disclose. I will mention an off-label use of a medicine that I'll point out very blatantly. And then I am secretary for GLAMA, the Health Professionals Advancing LGBT Equality. No longer the Gay and Lesbian Medical Association by name, but we are predominantly a physician organization with representation in the AMA. And so I will very selfishly talk a little bit about GLAMA and some of the resources we have out there, but we'll provide some alternative resources as well. So it's not just going to be GLAMA. And the really big disclosure I have is that we have an hour. I can't possibly cover everything you'll want to know about LGBT health. So trying to hit the middle, giving some background, a little bit about the different populations and about some specific things that you can implement, even as medical students moving forward into your further training and eventually clinical practice. So the next slide is really who are we talking about? And we use the letters a lot, LGBT. And that's really more of a convenience. It doesn't nearly capture the diversity of identities that we really talk about when we're looking at the specific needs of all these populations. And really lumping the letters together does a disservice to each of the unique communities, the L's, the G's, the B's, and the T's. And on the surface, you might see that, well, transgender has nothing to do with sexual orientation. It's entirely related to gender. But some of the struggles historically have been shared by all of these populations. So LGBT has sort of become the vogue thing to say. Sometimes we'll add the letter Q, the letter I, the letter A. Sometimes we'll put a plus. Sometimes we'll double the letters. It just sort of depends depends on the context and your audience and who you're working with in terms of sort of where they are placing the emphasis in terms of the alphabet soup of LGBTness, but for simplicity's sake, we'll use LGBT today. I did mention Q and I a little bit, Q, queer, and questioning. The Q really can apply to either sexual orientation or gender identity. As we all come into our own identities, we often are questioning and figuring out, you know, where am I along this spectrum? Where do I fit? And so a lot of your patients will come to you with questions about that. You know, what does it mean to be gay? What does it mean to be transgender? And so getting some background there will really help them answer questions. Intersex is there mostly just to make you aware. In medical school, you'll probably have an hour or two of lectures about differences of sexual development. That's a huge topic in treating patients who identify or who carry the diagnosis of DSD is a little more complicated than what we can delve into in this hour, and they don't always necessarily feel like they belong as part of the same alphabet soup, but in general, it is a population that can be higher risk for poor health outcomes as well, and so something we need to consider, but again, it's going to be a little bit out of the scope of today. And then more importantly almost sometimes than whether someone identifies as that L, that G, or that B, when it comes to sexual practices, it's who are they doing sexual things with is almost really more important, because a lot of men will identify as straight but have romantic or sexual relations with other men. Same goes for women. And so the identifiers we use in those situations are it should be MSM, men who have sex with men, and WSW, which would include someone who also identifies as gay and also has sex with men, or for women, lesbians there, but really sort of differentiating between identities and behaviors. And the next slide here, I love this slide. Write down this website, go find this, print this out, carry it with you. It really helps talk to other people about, you know, what do you mean gender? What do you mean sexual orientation? The gender unicorn here, some of you may have seen the gingerbread person that was sort of a precursor to this, but the gender unicorn is now sort of more accepted out there in terms of the rainbow there, how people think of themselves, their gender identity, male, female, or other. Do they even really fit into one of those categories? Gender expression, sort of the overall how a person presents themselves. And that's a little subjective, potentially, but still distinct from identity. The sex assigned at birth, you know, when they popped out of the canal or were pulled from the abdomen, if it was a C-section, somebody said it's and filled in that blank. And sometimes they have to take a pause because it's not always easy to tell, and sometimes that turns out to be completely incorrect because genitals do not make gender, we've learned. And so a little bit more about that in the future. Then people can be physically and or emotionally attracted to different genders as well. So what's coming from the heart and what's sort of driving sexual behaviors and romantic behaviors. So all of these things that are really part of sort of a comprehensive way of getting to know your patient. And it's confusing, yes. And so one way you can help clarify some things is on our next slide. My first practice pearl I have to share with you guys is really let the patient define their own vocabulary. So you're meeting a patient for the first time. Maybe they are a heterosexual male who is married to a female and is only attracted to females and only has ever had sexual relations with a female. And so the vocabulary will be pretty rote. You'll sort of know what to expect. But a lot of times, patients will have their own vocabularies, and you want to make sure you're not projecting your own assumptions onto them. So he, him, his, she, her, hers are pretty standard. Some folks who are choosing not to gender identify or don't have a gender identity will sort of use this pluralized gender neutral they, them, theirs, which sort of reconciling that with what you learned in grammar school is kind of hard at first, because saying things like they is doesn't really make sense. You have to try to figure out ways in your mind to get around that without making it sound uncomfortable around the patient if that's their word of choice. Other folks have tried to create or have created alternative words that are outside of sort of the generally accepted gender pronouns. Z-zers is one. I've seen it with Q before. And again, it's really what the individual decides. And then also part of getting to know the person is who is in their family, who's in their support system. And so making sure you're not using words like spouse or partner or boyfriend, girlfriend, unless they do. So really asking them, you know, who are they romantically involved with anyone? Tell me more about that person, using very gender, person, non-specific wording around that. So that's one of the ways that you can really try to help sort out, well, gosh, which of these letters do they belong to, and how can I really meet them where they are in terms of what they need in terms of primary care. Next, on the next slide, we'll talk a little bit about who we're actually talking about still. How many of your patients out there are going to have one of these identities? The Williams Institute out of UCLA is it's out of the law school there, and they do a lot of research around health policy. And sort of the most recent, largest consolidation of data out there, what we know in terms of person self-identity in the U.S. comes from them in 2011. There's not really been a big update of this since. At the time, about 3.5% of people identified as either lesbian, gay, or bisexual. And interestingly enough, despite that identity being fairly low, 8.2% noted that they have had a lifetime same-sex behavior, and 11% as same-sex attraction. So here we really see the disparity between the self-identity of the LGBT and then getting into that in men who have sex with men and men who have sex with women. So really this sort of tells us in healthcare that we need to be focused on those behaviors and then emotionally and mentally supporting folks who might be feeling same-sex attraction but aren't necessarily acting on that because it's just part of what they feel. And that's normal, and so how do we sort of navigate this with them? And sort of this data came from a bunch of national surveys that weren't really focused on collecting sexual orientation and gender identity data, but it was sort of incidentally in there. Somebody thought it would be a good idea. And then in 2013 is when the National Health Interview Survey, this is a large federally funded, sponsored, distributed survey, first started asking this question as well. And interestingly enough, the data is pretty consistent in terms of the population that self-identifies as LGBT, gay, lesbian, or bisexual, or something else besides heterosexual. They didn't drill down further there. So that seems to be consistent with what we had before. The good news is these questions are making that onto more and more federal surveys, so we're going to be getting more and more data. And that's important because we don't really have a lot of data now. And on the next slide, you'll see why. Patients don't like to tell us because they're afraid, and we don't like to ask because it makes us uncomfortable, because we're afraid, we don't want to ruin that patient-physician relationship. But honestly, it really contributes to it, so we need to be getting better about that. For transgender people, again, it's not an issue of sexual orientation, but a lot of times the treatments that they need or the screening or preventive services they need relate more to organs that they may have. And so if they don't, quote-unquote, look like they have a particular organ, then they may have difficulty getting access to services related to those organs. And so we need to know these things about our various patients. On the next page, a little bit more about that. You know, patients, again, providers are uncomfortable. Your system may not be set up to really ask these questions. It may not be a part of your culture in terms of your healthcare culture or your personal culture. These may not be things you talk about at your home, in your family environment with your friends. So they may be things that we have to become more comfortable with asking. You know, patients are afraid of being discriminated against, and there's a lot of movement in that area more recently, but for the past decades, people really haven't had protections in place to ensure that they were going to be treated fairly. And even now with those protections, there's no guarantee that individual providers or health systems will really, you know, follow the letter of the law, so to speak, and make sure that the environment is welcoming and appropriate for each patient. So moving forward, why is this important? You know, who are we talking about? How do we know? And why does it matter? It's because it's pretty much given that patients our LGBT patients face health disparities. We're on the next slide now, Allison. And so really being able to identify these disparities is super important, and having that data, knowing which patients are going to be affected is key. Knowing more about patients just is going to enhance the patient-provider relationship and really help you provide whole person care because you know about the patient. I can't imagine a proud parent coming in and telling me about how their kids did at school, but a parent maybe in a same-sex relationship with adopted or natural-born children being afraid to tell me how their kids were doing or that they even had kids, because I naturally would probably ask about the other parent, or is there another parent? And would I just assume that their parent were of the opposite gender and that they had a traditional relationship? Would I make those assumptions? And so making sure that patients aren't afraid to disclose just, you know, common social things about themselves, about their families. And really what the evidence actually shows that knowing about a person's sexual orientation and gender identity, it is as important as race and culture and religion in formulating individualized plans of care. Because if you tell a patient who goes to religious services on Sunday to every Sunday take you know, take your medicine at noon, but their services last well into the afternoon, that's a very physician-centered approach to care rather than finding out from the patient, what do you do at noon on Sunday, and is that going to make this care plan appropriate? So little things like that really do matter. It's kind of an example I just pulled out of nowhere. It may not make a lot of sense, sorry. So moving forward, talking about the way that I approach care of LGBT patients, the biopsychosocial model, biopsychosocial spiritual, you've probably heard before. Typically, you'll see this diagrammed as a Venn diagram with some overlapping circles with the, sort of the patient in the middle, and where these three different aspects of health and being sort of come together. But the way I see it with interacting with patients is, you know, physical health is at the center. That's usually why they come talk to me. You know, as a family doctor, I do a lot of mental health as well, and a lot of, you know, hand-holding and social support. That just comes with the job. But, you know, somebody with diabetes, they're never just a diabetic. You know, on the next slide, I like to put mental health into the picture as being almost a barrier sometimes to care for the physical health problem. These can often work hand in hand, and if you leverage someone's mental health strengths, then they can really make improvement to their physical health as well. But a lot of times, if someone has mental health concerns, that really is a barrier to providing or to them accessing care, potentially to them being able to be adherent with therapies or really absorb some of the things you're trying to do with them in the shared decision-making process. And really beyond that, even on the next slide, when you add in the social factors, wow, it's even more of a barrier to improving physical health or having an impact on physical health. You can imagine that when society tells you should feel a certain way and that makes you sad, well, then that can send you into spiraling depression, make you forget to take your diabetic medications, check your blood sugar, make you not want to eat right, and really sort of send the diabetes into a terrible spiral. So really looking at it as not just sort of this overlap of factors, but the direct influence of the social factors on behavioral mental health, on physical health, and really the barriers that can lead to. And really for LGBT persons, social stressors on the next slide there really are still out there. There's been a lot of success in recent years about marriage equality, obviously. That's not so much of a big deal. This is the first time I've given a big talk like this where I've been able to take out those slides and not talk about what's next or how that influences health. But we really saw you know, back then people really suffering from being treated as separate but equal if they had domestic partnerships or really unequal. And so issues like that, and on the next slide, one of the more recent topics in the media now is the transgender bathroom bills in North Carolina and other states. And you can imagine, you know, here are your two choices. Go down either hallway, go through either door, and it's going to be a bad experience. So how does that really affect patients in terms of being able to access and have good quality health care? And so you can see as we go through this, through the arrows here, the next one shows that, you know, discrimination can lead to isolation and fragmented social support. People can withdraw from society, from their friends. That's going to lead to those poor mental health effects, and they're not going to be taking care of themselves anymore. And then eventually, here we are, you know, physical health effects. They're not taking care of their diabetes. They're not taking care of you know, preventive things they should be doing for safer sex practices or whatever else it is, where we can intervene with them at the primary care level. And some of the specific disparities we see on the next page there, you'll see with lesbian women, they're still, even though the Affordable Care Act is here, they're still much more likely, less likely to have health insurance, to get preventive health care services. As a result, they have higher rates of breast cancer, lower rates of screening, and then higher rates of obesity and cardiovascular disease. We'll get to this a little bit more in a minute. On the next slide, men who have sex with men, you know, we always seem to focus on sexually transmitted infections when it comes to this population, but unfortunately that's where the disparities predominantly lie. And so we do see these really high rates of vaccine-preventable hepatitis, higher prevalence of HIV, syphilis, HPV, and then if for those populations that don't identify as gay or bisexual but are having same-sex contact, evidence shows that there is a significantly decreased risk of, or decreased use of condoms in that population, because using condoms actually sort of justifies, in a sense, their sexual behaviors, and gives it more of an identity, makes it gayer. Honestly, that's what patients or people will say in these studies that they do, these confidential studies. And so that's one of the reasons that people are more likely to have these barrier-preventable sexually transmitted infections. Bi men and women across the board have greater reports of stigmatization and higher anxiety and depression, and that's because they really get it from both sides in the sense that their heterosexual friends or heterosexual people don't necessarily think that bisexuality is a thing or a legitimate thing, and then a lot of gay men and women don't really see it as a continuum, that really dichotomy, either you're gay or you're not. And you can imagine trying to reconcile having an identity that other people will not legitimize to you, and that can be really frustrating at base, but depressing even, higher than that. On the next slide, transgender men and women, you can imagine, have a very high degree of marginalization. A lot of this is sensationalized in the media, but there is a high incidence of prostitution and drug use and sex work among patients who identify as trans, but not everyone. So please don't think that that's the case. Don't stereotype, but we do see that when we do population-based studies to identify risk behaviors. Coverage is still a big issue for medical treatment and surgical treatment, and so trying to fight those battles is very burdensome. And often patients can turn to illicit hormone use. We're using needles, seeking surgery outside of the country, some very legitimate practices, but some that are not very legitimate, putting them at risk. And then in general, no matter how young people identify or are trying to figure out how they identify, if they have any leanings towards any of these identities or think they might belong to any of these identities, they have a significantly higher rate of suicide completion, not just attempt but actual completion. And you do see this in the news quite a bit, unfortunately. But the good news is disclosure of any of these identities to their healthcare provider is an actual protective factor for youth at risk of suicide. So just having that relationship with a primary care provider is going to protect them from having well, they're still probably going to contemplate, but it's going to protect them from actually completing suicide. So that's a really positive thing, and hopefully one of the outcomes of educational programs like this is that we can really help start showing youth that this is a normal way to feel, and I'm here to talk to you about it. Excuse me. So then moving on, we know who we're talking about and that they face a lot of issues, but how do we make a difference? What about outcomes? How are we measuring those? And how do we know that the practices we put into play really are going to tell us in 1, 2, 5, 10 years that that was a good thing to do for patients to identify among these various communities? On the national front, Healthy People 2020 is the Department of Health and Human Services program. Healthy People 2010 was the first one. Healthy People 2020 is a huge revision of that. And then the Healthcare Quality Index from the Human Rights Campaign with some input from GLAMA back in 2007 when it first came out are two national programs I'm going to touch on here. First, Healthy People 2020, this really is the main document that guides on the next slide, prevention strategies on the national level. And since 2010, they added LGBT-focused categories. This is huge. It was a pretty significant affront to the LGBT communities when it was left out in 2010, because there were a lot of advocates back then really saying, hey, this is a huge at-risk population. If you're really targeting the most at-risk populations in the U.S. with prevention strategies, then you've got to include the LGBT folks, and that didn't happen. So 2020 was, when this was released shortly after 2010, this was a big deal. And really the emphasis here is on survey data collection. Earlier, I showed you some data that seems like it's pretty good data, but we don't know. The sample sizes are still pretty small. Some barriers to data collection involve willingness to disclose, because this hasn't really been a normalized thing yet. There aren't many surveys in the world where you take that asks you, are you gay or lesbian? You know, are you transgender? Right? Those are strange questions for a lot of people to hear unless you're a member of one or more of those communities and you're in settings where you get asked that quite a bit or you disclose that quite a bit. And then there are searchable databases online at healthypeople.gov. I'll have some links on here in orange to match the titles. You can go to there and you can sort of search, well, what are the other objectives and how close are the various states or other bodies getting towards meeting those objectives. One I found was interesting under adolescent health, it asks about, they're looking for a certain percentage of schools, 92% maybe, to have policies, middle schools and high schools, that prohibit discrimination of students based on sexual orientation or gender identity. And they say there are 88% nationwide of middle schools and high schools having policies like this. But we see every day in the news, there's a new incident at a different school. And so I wonder, well, is just having policies enough? So what's the next step that's going to come out of Healthy People 2020 and Healthy People 2030, I guess, that we'll talk more about actually real outcomes, because just having a policy isn't enough, right? We have to be able to protect students beyond that. Then the Healthcare Quality Index, this is an opt-in benchmarking tool that different healthcare facilities can use to evaluate their own policies and practices. And it's been around for 10 years now almost, and so a lot of healthcare systems are able to check the boxes. And this is another one of those where it's yes, we have a policy, yes, we have a policy. No, of course we don't discriminate. But what we're really seeing is that there's been no impetus to sort of innovate and develop best practices. And so the 2017 criteria that the HRC just released for the current scoring process really focus on they're moving away from just not discriminating, which is great, but we really want people to be more inclusive, more welcoming, more accepting. And so what are they doing? What best practices are they developing? And so you can actually look online, go and look at your own med school healthcare system if they have one, or where you're originally from, or where you might be rotating if you're on a rotation right now. And you can see if they participate, they'll have a score, and it will tell you a little bit more about the areas where they can improve. This is also a great tool whenever you are rotating somewhere to be able to engage leadership there at whatever level and say, hey, you know, this is something I read about online. I think it's really cool. Patients really seem to respond to it when I'm at other hospitals that have participated, even if the rating's not perfect. But how about using this as an outline for ways that you can make a difference within your own system? So I got really interested in sort of showing this around at UCLA when I was a medical student there at all the hospitals I would rotate, and in my last 2 years there after it first came out, and it was accepted with varying degrees of acceptance, I guess, but I thought it was a great tool for me to start thinking about ways that I could make a more welcoming environment, and we're going to get to that right now. So all this information, a lot about data, we're collecting data, we want to put it to good use, and how can you translate to practice? What can you do directly? So on the next slide, you'll see a couple of photos. There's the fancy schmancy LA LGBT Center. They have an LGBT-centered clinic in there that provides very comprehensive services. They get a lot of money from donors there in the community. But sort of on the other side of that is that in Augusta, Georgia, the students and the residents there in that picture, they decided, hey, we want to provide a safe space for patients who identify. We noticed there are quite a few patients who are identifying and saying that we need more services around here, so we want to start a clinic. So they did. And this is a model that's really been replicated in a lot of communities around the country, just identifying a need and then creating a response to that. But you don't have to have a clinic to be welcoming. That's really the big point I want to make. So really what you can do in primary care, you want to be welcoming as a provider, moving on to the next slide. And then in primary care, our greatest opportunities for intervention are the screening, prevention, and wellness. And then as a sort of an aside here, transgender care, yeah, you can do this. You can do transgender care. We're going to talk a little bit about how to get involved in that shortly. So first up, welcoming patients in. Again, I mentioned that it doesn't have to be in a clinic environment that's designed specifically to treat LGBT patients. Why? Because patients are just patients. They're human beings, and you know how to treat human beings, and you want to treat human beings nicely. So on the next slide there, you can see some very small things that can be done to make the environment more welcoming. AMSA has for sale in their store little rainbow caduceus, which I actually have on my white coat, but you can't see me for me to prove that. But I've had one of these on my white coat ever since I probably lost them 2 or 3 times and had to get a new one, but I've always worn one because it's really an immediate way to say to patients that this is a welcoming situation. I'm open to speaking to you about any concerns you might have related to your sexual health or gender identity. It's pretty innocuous. People who don't know what it means won't know what it means. If they ask you what it means, I usually just tell patients it designates a safe space. People can talk to me about anything. I'll just sort of have a more general response to that because I don't want to focus on why I'm wearing a pin when I'm there to talk about their concerns. I don't want to make the encounter about me. And then really having in your office materials that talk about this specific one out of, is this Fenway? this is Fenway, where it talks about why are we asking questions about sexual orientation and gender identity, but even just having posters or brochures in the exam rooms or the lobby that depict individuals who are not necessarily specifically of one gender in their appearance, same-sex couples, same-sex families. In my exam rooms here in my clinic, I have 2 rooms that I predominantly use, and I have posters up in those rooms that aren't necessarily in all the other rooms. Patients usually establish care with me a lot of times because they've heard that I take care of LGBT patients, and that way before they even meet me, they've gotten sort of an okay just by being in my exam room that, yeah, okay, this is probably going to work out or hopefully going to work out. So another big thing we keep talking about on the next slide is the electronic medical record, and I don't know how much success everyone has had in their institutions with this, but it can be a really big deal getting these set up correctly. And in 2011, the Institute of Medicine, the IOM, said that, you know what, you should be collecting this data. It should be just as simple as asking a religion, ethnic background, marital status, and the reason for that is that it matters in terms of health outcomes. At least we think. We don't really have a lot of data to be able to say for sure in many cases, but gosh, if there are all these disparities that we know exist because we get that in population-based surveys, well, how can we tie that directly to medical interventions or behavioral-based interventions or social services programs that we might be collecting data on in our EMR? So gosh, we should be putting this in there as well. And so really on the benefits of including sexual orientation and gender identity, SOGI, S-O-G-I is what you'll see in the literature around that. The benefits on the next page there is it really is a uniform way of collecting this data, right? Selecting something from a drop-down field, if everybody's doing that for every patient entered in the system, then it's going to be pretty uniform. We're on the next page, Allison. And then from that data, hopefully you can create targeted preventive health strategies, right? If you find that a specific clinic has 2,000 people who identify as gay, well, that's probably the clinic where you should be doing a lot of your population-based interventions around things that are hopefully going to help benefit gay people. You know, really in the long run, then collecting all this data, hopefully you can look back and do these retrospective analyses to be able to see if those interventions actually work. But if we don't have that data up front when we're asking people innocuous questions like, what's your address, you know, are you married, those sorts of things, then we won't ever really be able to assess for outcomes. And then meaningful use is something that's sort of fallen off the radar. This was something that in the practical world, physicians were initially getting reimbursed extra for if they did meaningful things with EHR that we were told to by the federal government, and then it became you're getting penalized if you aren't doing meaningful things. Meaningful use has gone away, but they are still working EHR into MACRA, which I keep forgetting what it stands for, and thought I put it on here. But it's sort of these newer ways of measuring, you know, outcomes at the clinical level, and what we're doing as clinicians to be able to collect data on our patients and receive payment appropriately. It's super complicated, but basically there is this opportunity for using this data for those purposes. Some of the challenges on the next slide you'll see is, you know, non-discrimination and privacy are huge issues. Just because we say we don't discriminate doesn't mean that you can guarantee that every office staff person, every nurse or medical assistant, every physician assistant, or other person in that flow of patient care is going to necessarily ascribe to the same beliefs. And so that can be give patients hesitation to disclose. Plus, who else is going to know? What if I tell you that I'm having sex with men, but you know, is my wife going to find out? And even though technically you can't disclose without a patient's permission, if they have a shared patient portal or you mail them something and it's included on there, even though it's HIPAA compliant, other people still could find out. And so you'll have to have conversations about that with patients. Again, just saying that I'm gay, I'm lesbian, I'm bisexual, that doesn't really capture behaviors. Even saying I'm heterosexual, right? We learned earlier, heterosexual people have sex with people of the opposite sex. So when we're looking for behavior-based risk strategy mitigation, well, just going after all the gay guys isn't going to capture every male who has sex with men. You're going to be missing a lot of patients who are potentially even higher risk, we saw earlier in terms of decreased condom use. And then so with all those things in mind, people are going to underreport, they're going to misreport, you know, they're going to, and that's a nice way of saying they're going to lie to the medical record because they don't want that written down anywhere. And then really, what's my incentive for collecting this information? I obviously see it as a very patient-centered approach to care and being able to provide whole person care. I need to know about that whole person, but not everyone perceives things that way. But the evidence shows it really does matter. All of my resources, by the way, references are at the end. I didn't do a very good job of linking them to some of the statements I'm making, but if you have any questions afterwards about doing that, I'm more than happy to share that with you. Then the diagram here on the next page, this is from crap, I'm forgetting the clinic in Philadelphia, I think, or maybe it's Fenway I pulled this from, and really just sort of highlights all the different places you can collect this data. So a lot of times patients are able to register for their clinic visits at home. I could do this for student health at UCLA actually, and I loved it because it meant I didn't have to talk to anybody until I got in the room to see the doctor. It saved me a lot of stress, whatever I was there to talk about. You know, when they arrive and they're checked in, they could actually register maybe at a computer on site as well. To disclose any of those different things. If at that point, all three of those locations, they still haven't disclosed, then there's a great opportunity for the providers to ask, for the nurse to say, oh, I see you skipped a question, or I see you left a question blank, or for me when I walk into the room, to just make it a part of my comprehensive physical, we'll talk a little bit, or physical, history gathering, and we'll speak a little bit more about that. And anytime they do answer, you put it in the database, you put it in the EHR. And they can always choose not to answer, right? People don't have to tell you what religion they are or what ethnicity they are or whether they even identify with any of those. It's all being patient-centered. They're allowed to not tell you, but it's all about shared decision-making, risks and benefits, saying, well, this is why I think it's important and here are the risks to you. If you don't share, I might not be able to tailor a care plan that's truly appropriate to your needs, to you personally. On the next slide, my practice pro number 2, this is a sort of a unique way of thinking about gender, right? We're always, most people are brought up thinking there's male, there's female, there's nothing in between, there's never any before or after. But really now the best practice recommendation for EHR specifically, but in general in talking to your patients, is to have this 2-question approach. Number 1, what is your current gender identity? Male, female, some patients will self-describe as female to male or male to female, to sort of let you know this is what I was and now, or was called, and now this is what I identify as. If they say trans man, that means they're male, but a transgender male. Trans woman or trans female, they're female, but trans. So a few different ways to say that you can see on the graphic. Some folks, again, they're queer, gender queer, they don't really feel like they fit into either box, and so they don't put themselves in a box. And then some folks will say other, or some folks will say dually gendered or two-spirited. They'll have various ways to describe that. So this matters because you want to make sure that you then ask them, or make sure you're using the right pronouns. You want to make sure that you're, if they're a female, you want to make sure you're speaking as though they're a female and not using language that's not appropriate. But you want to know what sex they were assigned at birth, because that probably is more in line with the organs they have. And saying what sex were you assigned at birth is a little nicer, more normal sounding than, what organs do you have on the inside, or what organs were you born with. But having this 2-step question really sort of helps get that on there. And having it on paper is a little easier than asking it out loud, but a lot of times when folks haven't self-disclosed to you by the time you see them in the exam room or whatever environment you're treating them in, then it's really up to you to ask these questions. So we'll move on to screening. This is another big opportunity in primary care. And again, I hate to focus on sexually transmitted infections, but really in primary care, that's what we do a lot of in any clinic, whether you see a lot of LGBT patients or not. So we'll start with HIV here, and for MSMs, USPSTF and CDC both say you should be screening at least annually. The United States Preventive Services Task Force actually says offer HIV screening annually to everyone aged 16 to 65. I live in the desert in Southern California in the Palm Springs area. I meant to mention that earlier. And so I have a very vibrant, very active older adult population here. And 65 is young for me sometimes. And so I definitely continue to offer that screening much later. The CDC goes on to say that sexually active men who have sex with men might benefit from more frequent screening every 3 to 6 months. And if they have high-risk behaviors, which would be unprotected anal intercourse without either a barrier method or a pharmacologic method. We'll talk about PrEP here in a second. If they concomitantly use IV drugs or party drugs or have sex for money or give money for sex, then yeah, they should be tested more frequently. Whenever you're checking for HIV, especially in places where HIV is very prevalent, you should be checking for syphilis as well on an annual basis, or as frequently as you check for HIV, especially among men who have sex with men. In San Francisco, there was a syphilis epidemic not too long ago, and I think it's actually still probably ongoing because they really do travel hand in hand. And then for gonorrhea, chlamydia, anatomical site testing, that's not something that we really talk about quite a bit, but really you can get gonorrhea and chlamydia pretty much anywhere you can have sexual activity. So not just saying pee in a cup, let's check your urethra, but what about the rectum, what about the oropharynx? Where else should we be checking for gonorrhea and chlamydia? 80% of carriers with oropharyngeal or rectal gonorrhea or chlamydia are asymptomatic, meaning that they can pass that around to anybody else who comes into contact sexually with those body parts, and they'll never know they're giving it around until a partner tests positive, and then they might get contacted if that person identifies them as a previous sexual partner to get tested. So you always want to try to intervene early to prevent, right? We're screening for the purposes of prevention. The next screen there, or next slide for STI screening, really there are a lot of barriers to discussing screening. People don't want to talk about sex. Universal screening, which is where we just screen everybody using the same guideline like the USPSTF recommends, and that's not to say that their recommendation is limited, it just doesn't take into consideration risk behaviors. That's the point of it being a universal screening. But when we also consider risk behaviors, then we might capture HIV infection on a more regularly on an earlier basis that can really help us intervene and prevent development of opportunistic infections or progression to AIDS and other AIDS-defining illnesses. And then really what we know from the literature is that when we recommend more frequent screening against high-risk patients, then they're more likely to get screened. So saying come in every 3 months and get tested, I say that all the time, and I hopefully see them at least every 6 months to get tested, which is still better than every year or not at all. So really keeping them engaged in care that way, your patients who are high risk. My next practice pearl here, really just talk about sex. I know in medical school we talk about these very specific ways of, now I'm going to ask you questions that I ask all my patients, and sometimes that's maybe appropriate, but I really say avoid that dramatic buildup. Just to ask questions, just make it a normal part of the flow. Don't set up the stage for there's a right answer to this or you better get this right. A lot of times patients will tell me they feel that way when there's too much buildup. And then don't assume anything, not anything at all. Just because someone is 70, has been married to his wife for 40 years, does not mean that she's the only person in his life. So really just very frankly, ask about sex. What does sex mean to you? What does sexual health mean to you? And then getting at what we need to target in terms of screening. When you have sex, what gets put where? And most patients who have been asked this before will giggle because it's just it's a strange question, but really that's what matters. If they're having sex with 100 people, but sex to them is just body contact, for example, well, that's less of a deal than having sex with one person that's through multiple orifices without any barriers, either pharmacologically or otherwise. That's probably more important in terms of the patient you need to screen for potential infections. So, one of the things we talk about with sexually transmitted infections is women who've never had sex with men, there is still some risk there, but you want to be careful that when you're not assuming things, that you're not assuming that, oh, just because you're a lesbian now doesn't mean you used to once have sex with men. So really take their history, get this information from them. And so a woman who's never had sex with a man, she's probably not at risk for HIV unless she's had other risk behaviors. So don't force her or encourage her into annual HIV testing without a real discussion of risks and benefits of that testing and if it really is going to bestow any benefit on her. In terms of screening for HPV and anal cancer, the next slide here, rate of anal cancer in men who have sex with men is higher than the regular population or the rest of the population. There aren't really universal recommendations at this time for screening for the way we do in cervical cancer for women. But we know HPV does live in the rectum. I have some more slides in a second to go over that a little bit more. But in 2013, the Infectious Disease Society of America did say that HIV-positive men should be screened annually. They said there's moderate evidence and it's a weak recommendation. And then if there is a positive screen, then you should have high-resolution anoscopy and biopsy. But the CDC, as recently as 2015, says there's really insufficient data to even screen HIV-positive people. and definitely not HIV negative men who have sex with men. And you'll find a lot of practitioners, especially in San Francisco, New York, even here in Palm Springs, who find this ludicrous that you would not screen HIV-positive persons for the precursors to anal cancer because there is such a high prevalence there. The next screen just has a little bit of the progression here. So just like CIN for your cervical intraepithelial neoplasias, NAN really follows the same scale. You have this mild dysplasia that starts with the anal warts and goes into this grade 1. We do a lot of watching at that end of things, but then it progresses to the grade 2 and 3, the moderate severe, and then actually becomes cancerous. And so when you do the anal cytology screening, you can see it's much less invasive than a pap smear. You just really need a dry cotton swab, and you put it in a particular medium, the same as you would for cervical cancer, or you create a slide the same way you would for the pap smear. But really, if it's normal, you're just going to repeat, you're going to screen as you normally would. But if it's abnormal, you're going to have this high-resolution anoscopy, which is basically anoscopy on a video screen. You're going to use the same acetyl white staining method that you use for a colposcopy, for those of you who've done gynecology procedures and rotations, and any suspicious-looking areas where the active HPV area absorbs this acetic acid and turns white, you're going to biopsy those areas or take random biopsies if you see nothing. And then if it is this higher grade dysplasia, this 2 or 3, then you're going to treat that. You're either going to use electrocautery, chemical process, surgical process, depending on how large of an area is there, all towards preventing anal progression to anal cancer. And I get a little bit more about this in the next couple of slides. Or sorry, the next section here. But going on in terms of screening, because right now we're still just talking screening. So moving on, so mood disorders, large studies have really shown that patients who identify among sexual minorities or with a gender identity that's not, sorry, I'm using my vocabulary here. I don't want to say not standard, but someone who identifies as transgender or gender nonconforming, they really are at greater risk for significant mood disorders. And so in women, if they're bisexual or have sex with both men and women, they're significantly more at risk. Men, if they're gay, if they're attracted mostly to men or mostly to women, but still have same-sex behaviors, or they have sex with both genders, then there's a significantly higher risk, and that's for depression and anxiety. So you've got some well-known screening tools that are very, very validated in the general population. We know now that the PHQ-2, which screens for depression, is just as good as the PHQ-9 for actually screening patients who are clinically depressed. And the DAS, which is the drug abuse screening tool, is much longer. There's some shorter things around for that as well, but for looking for co-occurring substance abuse disorder, which are also much higher in these populations. Currently, there's some research into, is there a better tool for screening patients who identify as LG or B or T, or who do have sexual activity with members of the opposite sex or both sexes, but there isn't really a specific instrument out there that's validated for use yet. So these tried and true ones do seem to work. Another screening, the USPSTF is currently updating its recommendation on intimate partner violence. The next slide, they currently recommend that we only screen women of childbearing age, but the Department of Health and Human Services does recommend universal screening. So again, universal, every person, no matter what other characteristics they have. And so the hope is that this universal screening does catch the higher prevalence of intimate partner violence among folks who identify among sexual minorities. In many cases, you'll see here, heterosexual women, about 20% have reported a lifetime incident related to intimate partner violence. Lesbian women are actually seem to be at worst the same as heterosexual women, so maybe that's a little protective, only having relationships with other women. I don't think the data has actually said that explicitly, but you can see there bisexual women, gay men, significantly higher rates of intimate partner violence, and this does not take into account transgender status. We do have significant data to suggest that there is a very high rate of intimate partner violence, but because transgender and sexual identity are two separate things, it's hard to correlate them necessarily with this data, and the population surveys that have been done are not very large, so that's an area of ongoing research there. moving on to prevention, I know we're getting close to the end of the hour here. This is where a lot of the meat is. So we'll talk about a little bit about HIV pre-exposure prophylaxis prep. And this is an entire hour-long lecture in itself. Emtricitabine, tenofovir, under the brand name Truvada, is indicated for high-risk men who have sex with men. Specifically, that's what this talk is about. There are other studies that have shown benefit in IV drug users. But it is part of a comprehensive strategy that includes condoms counseling and regular STI testing and treatment. So basically, a patient engages in high-risk sexual behavior. You've done a high-risk sexual behavior screening tool, which I don't have listed on here, but is available through the clinical practice guideline link you can see there. And patients who score high enough on this survey, or basically say that they are high risk, or you assess them to be high risk based on your history and physical, would likely benefit from this once-a-day combination therapy aimed at preventing contracting HIV. So even if they have sex with partners who are HIV positive, multiple partners of unknown status, intercourse or sex while under the influence of IV drugs or party drugs or for money, then that's who this medication was tested on and indicated for. And so what we see is that initially in the studies, when you look at drug studies, there's the optimal use, like birth control is a good example we often compare to. If you use birth control like you're supposed to, you're probably not going to get pregnant. But if you only take it once a week, you're probably not going to get pregnant. So pretty much the same way with Truvada for PrEP. When used appropriately and when the drug trials were able to detect the medication in the bloodstream at the appropriate levels, we really saw that in these retrospective analyses of the data after the fact, that really it looks to be as effective as condoms alone, or maybe even more effective, because condoms, again, perfect use means you use a condom every time, not, oops, I forgot, or I was too drunk. And so over the last 2 years, where a lot of this 2 to 3 years, where a lot of this population data has really been gathered in studies, as the uptake of Truvada for a PrEP indication has really skyrocketed, we're seeing that real life does seem to mimic the initial studies. So that's promising. So stay abreast of that. You can see the clinical practice guideline the CDC put out in 2014, because they really did see significant changes to their HIV statistics right away. And then the manufacturer has a risk evaluation and mitigation strategy website that has sort of a little tutorial about it on there as well if you'd like to learn more. I would recommend looking at both of those if you're interested in finding out more. Again, this is an entire hour-long lecture of itself. Real quick on the next slide, we talked about Hep A and B previously before, fecal oral transmission there, so it makes sense that individuals, not just men who have sex with men, but anyone who engages in sexual activity that involve oral anal contact would be at higher risk for this. So the CDC says, hey, since this is especially prominent behavior among men who have sex with men, vaccinate for Hep A and B if they're not already immune. You guys know there's no Hep C vaccine, but still talk about risk factors. And if they are high risk, if they were a baby boomer, or if they're HIV positive, you do want to make sure you do at least a one-time screening for that, and then continue to follow them for their risk behaviors, but definitely get those vaccinations in place if they don't already demonstrate immunity. Again, it's all about behaviors, not just the gay men, the bi men, or the men who have sex with men even, but men who have sex with women, women who have sex with men and women. If they're engaging in oral anal behaviors, then ask them about their hepatitis status, or even you can check that through their serology titers. Hepatitis B vaccine, sorry, not hepatitis B, sorry, HPV vaccine. This is really exciting research to me that came out in 2011 when the quadrivalent vaccine first got on the market by the FDA. Now we have the non-valent vaccine, so if anybody getting an HPV vaccine in clinic these days, it'll protect against 9 strains, so the most virulent in terms of causing the CIN and anal warts, or sorry, cervical wart, genital warts. So this is even more vast-ranging, but from the original data, the original trial, they found that 60% of all men in the trial are penile carriers, even if they've never been able to say, yes, I've had a wart on my genitals. And so that's pretty significant in terms of protecting people in general from HPV. Men who have sex with men, of course, are disproportionately affected. So 65% of HIV negative and 95% of HIV positive men who have sex with men are anal carriers, whether they've ever had an anal or perianal wart before. And this blew my mind. Up to 25% of men in this study who've never had sex with men. This includes, young boys down to the age of 9, which is the study population, ages 9 through 26. 25% of those males in that study are anal carriers of HPV. So this isn't just, a quote-unquote a gay disease or for men who have sex with men or people who have anal intercourse. It's HPV sneaky. It likes to go places it likes to go. But we do see anal cancer is 15 times more prevalent among men who have sex with men, and this doesn't vary by age. So which is interesting is even though we start to clear AIN less as we age, like women will clear CIN less rapidly as they age, we really don't see for the HPV that the prevalence is any different because it does like to sort of sit where it likes to sit in the anal mucosa quite a bit. Women who have sex with women, transmission is possible. It is a skin-to-skin contact transmission, so if women are sharing toys, if they're having intimate genital contact, then it's entirely possible that they will transmit. That's not something that's case reportable. It happens often enough. But the good news is, on the next page, the HPV vaccination is pretty effective. So looking at males specifically, because we should universally be vaccinating our women aged 9 to 11, at that time they haven't really developed sexual identities yet, often, although sometimes they have. But the goal is to catch folks before they're sexually active. And we sort of downplay, our parents will tend to downplay the need in men, but in the study, they were almost 90% protected against external genital lesions. So if you can spare your child, penile warts in the future, that, as you saw on the previous slide, he's, 90% chance that he'll be a carrier in the future. He's going to give that to somebody else down the road, or sorry, 60%. Then why don't you do that for him? And then in men who have sex with men specifically, there was actually similar protection against genital lesions, but pretty significant protection against this progression to AIN, including the high-grade AIN. And then also interesting, after someone with high-grade AIN was treated for it, if they were then vaccinated, there was a reduction in their lifetime anal cancer risk. So the vaccine seemed to protect against other strains and against recurrence of the initial strain. Now, there's some newer evidence that is not necessarily in line with that, but there's nothing definitive yet. So there is this potential for benefit over the lifetime. So I've left that in here today. Moving on to wellness, gosh, we want to keep our patients well, so what can we do there? We talked about obesity earlier in lesbian and bisexual women. They're just not sufficiently physically active. Again, we're not stereotyping. This is what population-based research says. When women self-report, how many women who identify as lesbian or bisexual self-report this data, they're not meeting the recommended daily or weekly activity guidelines. There was a study in 2009 that said there is a greater degree of body acceptance within the lesbian community. Again, every patient is different, so don't necessarily assume that every patient you have will fit what this data says, but this was reported in the literature. And sometimes that's because they don't want to conform to what straight people, what's heteronormative is the fancy word to say that. So they can be their own person, and maybe one of those ways is having greater body acceptance. And additionally, being discriminated against also can lead to poor coping strategies. Binge eating and alcohol are things that are specifically mentioned in the literature. In my patients, especially as people are getting older and older and LGBT persons are living longer and longer, we're seeing that there's a higher incidence of these chronic diseases. And so intervening early on and thinking about, in 20, 40, 60 years, your patients are still going to have diabetes. They're still going to have HIV. People are living that long these days. They're still going to be at risk for developing cancers of old age. So how can you intervene now to get them to not be smoking, to not abuse substances, to have healthy use of substances, to help them get care for mental illnesses and help prevent these social and societal factors that may be leading to the mental illness, mental health issues that aren't letting them get into care and stay in care. We're finding that people have varying degrees of financial security. Relationships are sort of being redefined over the past few years, and older people may not necessarily feel the need to remarry just because they can if they're in a same-sex relationship. Of course, transgender persons really struggle across all of these societal domains sometimes because of factors they can't control, and so really working with them to make sure they have good social support and community engagement is really key. So those are some specific things that you can do in terms of wellness. So I'm sorry I'm rushing here at the end, but we're out of time. But the big thing here, this is a big one, and this is a, gosh, you know, their entire conference is just on transgender health. But really, what I want to get impart upon you today is that this is something that you really can do as a primary care provider at whatever level. Depending on your comfort, whatever training you have, whatever mentors you have available, you really can get involved in transgender health and make a difference. So on the next slide, in 2013, gender identity disorder was done away with when the DSM-5 came out from psychiatry, and it's now gender dysphoria, and it really focuses on the fact that it's a mental state rather than a disorder, which is obviously a terribly charged word. Dysphoria just means it doesn't quite feel right? But to a significant degree that it's pathologic, and so it really, rather than a physical or a mental pathology, it's more on the mental state, and it's causing problems. You don't have to have had surgery or have used hormones or be thinking about those things to get this diagnosis, and this is really important because kids as early as 3 years old are really starting to express transgender identities, saying, you know, Mom, when is my penis going to go away? Or Mom, when am I going to get a penis? And clearly those aren't individuals that would have thought about surgery or hormone therapy, but they're experiencing this gender dysphoria if they go on to say things like, you know, because it makes me sad to have one because none of the other girls have a penis. Why am I a girl and I have a penis? And that right there is gender dysphoria, and you sort of watch that as they mature towards puberty. And again, another lecture there. But this is, you know, fortunately, this sort of biopsychosocial approach really helps us grab a hold of this at the primary care level and start to intervene there to be a resource to our transgender patients. Some other things about transgender health on the next slide there is, you know, physical exams. You don't have to do them just because a person is transgender. You know, do them when they're necessary, just like you would for someone else, keeping in mind that, you know, a trans man who was probably born with a vagina and other female parts will still need pap smears based on regular screening criteria. Bimanual exams are no longer recommended for routine screening, but if they have vaginal bleeding or they have pelvic mass, then you're going to be doing bimanual exams to examine those things. Trans women who were assigned male at birth but identify as women now probably have a prostate. So whether they're choosing to screen for prostate cancer or they're having urinary symptoms, you're going to consider doing a prostate exam at that time. And breast exams based on hormone therapy, if they've had hormones that will you know, increase the amount of breast tissue they have, that does predispose them a little bit more to breast cancer risk. If they have any problems, if they've had surgical augmentation, those are indicated reasons for doing exams. But you're never going to want to do an exam or because they've had that done before. A lot of older trans patients will say they did an exam on me just because. And maybe the provider wasn't doing an exam just because. Maybe they had medically indicated reason, but that's why communicating with your patients is so important and making sure they understand the medical reason and give consent. They can always refuse that. Please, you know, talk with that about them. In terms of transitioning topics, they're going to come to, your patients will come talk to you about will be hormones for cross-gender, gender affirmation, and then surgeries they might be interested in. But not everyone has to be interested in those things. That's why I put that on here. You don't have to actively do these things to live your true identity. And then I mentioned earlier, they do have higher rates of violence. So these are all reasons to really, at the primary care level, make sure transgender patients are in care and make sure you're working with them to see that they're meeting their health care needs. The next slide, the UC, oops, I messed that up. The UC San Francisco Center of Excellence for Transgender Health is an amazing resource. The website's on here, I think 2 slides from now, or the next slide. They did a big needs assessment. They found that there were a lot of trans people who wanted primary care in their own communities. They didn't want to go to the Center of Excellence, even though those things are great. They just want to go see their doctor and get care in their clinic in their community. And of course, there are centers of excellence in big cities, but not rural areas. And so this is what led them to say, hey, you know what, this really is a primary care issue. Let's emphasize that and create some protocols. So the next slide you'll see on the website there, they did just that. They created these protocols, and it talks about all these different topics. And these are, you know, 1, 2, 3, 4 pages as you scroll down, and I use these a lot in teaching in clinic when we have a transgender patient establishing with a resident, or when they sort of want to know what's the next step in hormone management, or what labs should I be getting on a regular basis beyond just the regular, they're a human being sort of labs. Is there anything particular they should be getting? And all of that is detailed pretty significantly there. So definitely write that down, bookmark that, go there and do more. And then in terms of access to care, sure, trans people can come into clinic, but you know, how easy really is that for them? And once they're in clinic, are they going to be able to get the services they need? So the Affordable Care Act has done some great things, and one of those just this summer was clarified, Section 1557, to prohibit sex and gender identity discrimination. And so what this means is that just a woman, my example here is about women, so that's why I'm saying woman. A woman, you know, can't be identified, or sorry, denied services just because she's a woman, and that was extended, and this is almost landmark, to include anyone who identifies as a woman. So that really brings in gender identity, and they very explicitly said, yes, this does include gender identity. So fortunately, the Affordable Care Act says that if a trans man, you know, lives and identifies as a man but was assigned women at birth and has ovaries, if he gets ovarian cancer, then all of the healthcare plans out there have to cover treatment for that ovarian cancer. He can't be discriminated against because he's a man with ovarian cancer. And that was happening, and that's why this came about. Unfortunately, the states still determine whether gender-affirming treatments are covered. So if that same trans man says, I want my ovaries out because I'm a woman, I'm sorry, because I'm a man and I shouldn't have ovaries, then that's up to the state to decide whether that's covered or not. California is one of those that is pretty progressive in that regard. There are others, and there are a lot of organizations on the federal front that are really working to standardize this across states to really decrease the ability of states and insurance providers in those states to deny services like cross-gender hormones that really help a person live their true identity. So really, how can you do transgender health care? You can be a primary for transgender patients. Some patients will request that they maybe want to see an endocrinologist to manage their hormones, and that's fine. You know, they're entitled to do that, especially if it's something you don't do. But certainly you can get that same training and be able to provide that service as part of the whole person care you're doing in primary care. So moving on, just overall practice recommendations we talked a little bit about today. Never assume. Sexual orientation, sexual behaviors, or gender identity. Just, you know, ask those questions in a very nonchalant way. I would recommend against a lot of that build-up unless you have to build up to it to get that box checked on your OSCE for your standardized patient exam, then do it then, but sort of figure out what you're comfortable doing and what you feel like patients respond to, you know, really what's making them more likely to disclose to you. Participate in the EMR data collection. If you're seeing a patient and that box is blank in the EMR, you know, fill it in, ask them. I told you how. And then more frequent screening for sex with men for HIV, regardless of their risk factors, and certainly even more frequent screening if they do have risk factors. The next slide, all patients for intimate partner violence, we'll see what the USPSTF says, hopefully later this year. But for now, the HHS does say screen everybody. And again, you saw the higher prevalence of ever in lifetime violence against everyone who identifies across the LGBT, except for maybe those who identify as lesbian. Go ahead and vaccinate your men who have sex with men to age 26 for HPV, and that's because they're the under-targeted population right now. Everybody's targeting women because cervical cancer is really, really bad. We want to prevent that. We're doing a pretty good job with boys sort of in general, but we have this higher risk population we could target better. And then actually here's my off-label recommendation. Consider vaccinating after age 26. 9 strains of HPV. There are people out there who probably have gotten all 9 and have all 9 of them in their body and may not benefit from the vaccine, but they probably don't, and they probably will benefit from the vaccine. So consider that, because the vaccine trials you saw, there is decreased progression to anal cancer after treatment for high-grade AIN. And then become familiar with those transgender primary care protocols. Just know they're there, know there's something you can access, and as you go through your training, you can have those to refer to. On the next slide, look for resources that you can share with patients. Glenn has some handouts here about 10 things that transgender, LGBT, we have 4, should discuss with their healthcare providers, and it's a lot of the same stuff we talked about. It's really saying, hey, your providers need to know about these things, bring them up because they may not. You can find rotations out there. I don't have a list, but this is something that was going across the Family Medicine Program Directors listserv recently about programs that had high concentrations of LGBT patients to be able to give students good experiences in primary care with those populations. So there are clinics and systems and communities out there with that, so look for those. And then seek continuing education. There's a lot of free stuff online. There are a lot of conferences out there as well. And then in the GLAMA provider directory, it's a free service we offer for patients to look and for providers to list. You can put yourself in there once you're a provider and say, I'm open to seeing LGBT patients. And you can put a little bit more about your practice. And a lot of folks were hesitant to sort of put their names in there because they thought maybe someone will think they're gay if they're listed in the directory. Well, then we have a straight for equality designation, so you can actually say, hey, I'm straight, but I still care, and I want to make a difference in your health. So feel free to take a look at that and see if there's anybody in your area. We actually have a capital campaign going right now to improve this database, so please forgive the fact that it looks like it was designed 10 years ago, because it was. We'll hope to update that soon by the end of the year or early next year. But the information is there, and right now that's the key thing. So in summary, we saw that social factors really do influence the health of sexual minority and transgender men and women. It's a complicated picture, and I could talk for hours and hours about the sociological influences there. We saw some evidence-based interventions that can really come from understanding a biopsychosocial model of health. We have to be able to collect this data to be able to put those into place. And then I hopefully showed you some specific ways that you can really directly impact care by screening, focusing on wellness, making sure you're identifying your patients who are at most high risk. And then as we go forward with research on this, we'll really hopefully be able to see that that helped in the long run once we actually have the data. I have some additional resources here. The AMA has an LGBT advisory committee. Fenway is a great system in Boston that's focused on LGBT care. They take all comers, so to speak, but they really have developed a lot of provider training materials, videos, brochures, patron engagement materials. So really check that out as a first stop for looking for patient materials. You can also just Google it and find some stuff out there. And then there are actually a couple of journals now that have come on in the past couple of years. GLAMA had a journal once upon a time, but there was sort of this dearth of high-quality research coming out. But now, as we're actually collecting data in EMRs locally and at the national level, we're actually able to have really high-quality studies. So like my little study I did, I'm really proud of it because I went out in the community. I did this needs risk assessment in Ventura where I was in my residency because there were no LGBT-focused services there. I was really excited about that. Now they actually have a transgender care clinic in the county healthcare system. So one of my fellow residents actually runs that now. We started that after I moved away, after my training ended there. So, even little things come out of the community-based research, but we're seeing that research is a much higher quality now at the national level. So I've got a bunch of resources. Like I mentioned, I can tie those to anyone who's interested, and my email address is on the last slide. I had one question that somebody's asking, individuals who identify as bisexual, why are they more at risk for mental illness? And the evidence really shows that they face greater discrimination from more fronts. A lot of people don't necessarily recognize bisexuality as a legitimate sexual identity, a sexual orientation, and so that's within the gay and lesbian communities. So they will discriminate against other sexual minorities in that way, and so bisexual persons often feel that. Oftentimes they'll describe in interview-based research that they have sort of this inner, they seem to have more of an inner dialogue with, am I really bisexual? Maybe I really do like men more, maybe I really do like women more, and this seems to translate into greater anxiety and stress around that. So that really is the crux of the research around bisexual orientation and mental illness behavioral concerns. So. Great. That's what I had for everybody.
All right. Fantastic. Thank you so much for speaking with us. I know we're running short on time, but were there any other questions that people had really quick? All right. Well, if not, thank you again for speaking. And for those listening, please tune into other presentations that we have for the rest of the week for National Primary Care Week. Thanks so much for coming, everyone.
Thanks, everybody.